Good afternoon, everyone, and thank you for joining our final session of the 2021 North Country Leadership Summit, Emerging from a Year of Change, an Opportunity to Rebuild and Reimagine. This is being put on by the Adirondack Health Institute and Fort Drum Regional Health Planning Organization. We'd like to take a moment to thank all of the sponsors for this year's summit. Without your support, we would not be able to host this event. So thank you all for the continued support over the years. A few housekeeping items before I pass it over to our speakers. Please place any questions for our presenters in the chat, and we will ensure that those are addressed during the Q&A portion after the session. All attendees, please remain muted with your video off for best broadband connectivity and to reduce distractions. And finally, all presentations are being recorded and will be archived on the North Country Leadership Summit webpage by October 1st. Now I would like to introduce our speakers. Today we will be hearing from Dr. Alex Marsal and Dr. Kevin Martin, and they will be presenting on the role of telehealth in advancing integrated behavioral health care. Please take it away.
Thank you. Thank you for the introduction. I would like to say it's a pleasure to be here on behalf of myself and Kevin. I think that it's an opportunity for us to talk about something important. I think that the world healthcare and behavioral healthcare has changed, and I think that this is an important discussion for us to have. Kevin, I'm not sure if you want to add anything.
Well, I'd say I'm excited to be here as well. I know that Alex has participated in this conference in the past. This is the first time I've had the pleasure, and I am relatively new to telehealth myself, and Alex is old hat at this as much as anyone, I think. So I think between the two of us, we have an excitement. Maybe passion is a little much, but we have something exciting to share today, particularly in terms of where we've come and where we think we can go. So let's start by looking at behavioral health crisis. This is certainly not unfamiliar to us. If you look at the left side, data here from Mental Health America, so 44 million US adults, about 14%, experience mental illness every year, but only 45% of those, or about 20 million, are treated. There are a lot of reasons for that. We'll talk about some of those, but that's not at all a good statistic. And we'll go into some of the reasons why that's a problem, that this untreated mental illness leads to other difficulties. On the right side, we have some data here from an employee survey by Qualtrics that measured during COVID, asking people about their stress, their anxiety. And as you can see, these are really impressive numbers. We've all experienced this, so maybe we're not surprised, but it's a little shocking when you see the actual numbers. 67% of people reporting higher stress levels, 54% reporting being emotionally exhausted, 50% more irritable. I believe that one. We deal with people every day. The sadness, the mental health decline. So this is really significant. I can say that prior to coming to aptihealth, I was working in a psychiatric hospital when COVID hit, and really until May of 21. So for more than a year during COVID. And what we certainly noticed was that particularly in the summertime, when our numbers of children and adolescents needing inpatient care normally drops quite significantly, and numbers of adults drops a bit, we didn't experience that at all. It was really historic in the 30+ year history of the hospital that we were full and more people needing to come in the hospital than we had room for. And this really it related to the stress that everyone was living with, people who already dealt with anxiety or depression, had exacerbations of their symptoms, and many people who had no prior history were suddenly needing care, particularly a lot of children and adolescents.
For me, this slide speaks to, I've had conversations with other organizations about collaborating. And one of the frank conversations we have is, are we competing? And I'm always puzzled by that, because I'm thinking 55% of folks don't have access or get care. We're not competing for the 45% that do get care. We would like our goal to be to reach the 55% that need care and don't get it. So for me, when I have conversations with other organizations and we talk about, competing, it just doesn't make sense to me in the face of this statistic.
So also in the behavioral health crisis, medical costs and spending is a result of the lack of available mental health care. So looking here quickly, you see on the left, this is Medicare population data. So you see $13,000 approximately a year average annual medical costs for Medicare individuals. You increase that 26% to the black circle, 15,500 for those who have mental illness versus those who don't. And then mental illness along with medical comorbidity, another 17%, up to nearly 20,000 a year. And when you look at the breakdown of where those costs go on the right side, you see that the two most expensive areas to begin with, hospitalization and ED, where the largest amount of healthcare dollars go, also experience the greatest increase in cost with mental health patients.
I think that the cost makes us in behavioral health relevant. I think if the costs weren't so considerable, then I think healthcare dollars would go elsewhere. But given what Kevin just said, I think it makes behavioral health relevant in terms of healthcare.
So we know also, to make the case further, that mental health plays a significant role in a patient's medical comorbidities, and really vice versa, bidirectionally. So here we see that approximately 29% of adults with any medical condition also have some type of mental health disorder. And there are even some of these more specific data on the right. For example, the other direction, 70% of behavioral health patients have one or more medical comorbidities. Studies in patients with cancer showed between 15 to 25% of cancer patients affected by comorbid depression, which is certainly higher than you would expect the rate of depression generally in the population. In studies of patients with diabetes who also have depression, 5 to 30% of people with diabetes, depending on the study, also have depression, which then results in worse outcomes. And up to 33% of those who suffer heart attacks later experience depression. That one is interesting to me, particularly because many years ago as a child, when I knew nothing about comorbidities or mental health, it was something that I observed in people around me and in older family members, and was told that this is not unusual. It was just something that people knew very well, that many times after a heart attack, people would have a change in their mental status where they would become depressed.
I think that Kevin and I are going to talk later about sort of the future, but if you look at it, simply he's saying that every medical specialty, oncology, cardiology, that all medical specialties have a percentage of individuals that experience behavioral health. And for me, that means two things. One, it encourages the medical community to more embrace behavioral health. And two, it challenges the behavioral health folks to become more medically versed, so that this way we can kind of, bridge the divide, if you will.
And it points out the fact that the large number of people with mental illness is not being treated certainly includes some of these people with the comorbid medical issues. So we're not really treating the patients effectively if we're not treating their medical conditions and their mental health as well. So there have been attempts at integrating behavioral health and medical treatment over time, and different models, approaches have been used. A little bit of the history of this. At the top, you see co-location. So this is something that's been going on for some decades in various forms. Basically, it means locating services in the same physical space, but not necessarily fully integrated with one another. Rates of co-location are around 26% in rural areas, but up to 46% in urban areas. The evolution over time then has led to what we'll term collaborative care, which is more integrated, often involving evidence-based practices, but really requires a huge change in the way that a physician practice is managed. These kind of collaborative models often leave the primary care providers responsible for psychiatric prescribing as well. And so these are complicated and again, not necessarily financially sustainable any more than the co-location has often been. Then we come to telehealth. So we know, of course, that this is, we'll talk about this further, telehealth is accelerated during COVID, but even before then, the experience with telehealth transitioning from traditional care models to telephone or video communication tools is a way, particularly for behavioral health care, to be perhaps more available, more easily integrated.
I think that the challenge that Kevin and I sort of look at is, what have we learned from these approaches, and what can we improve? Telehealth being the most recent, but how do we develop an approach that improves the shortcomings of previous approaches?
Exactly. So looking at telehealth specifically, so if you look at the left, you'll see down below the green, in 2019, patients who were asked, only 11% of patients expressed an interest in using telehealth. But then once the pandemic hit, those numbers went up to 76% who are interested, and 74% of those who have used telehealth now report high satisfaction. And this isn't limited to behavioral health care. COVID's role in this is well known, but the statistics, I think, make it even more impressive. So providers reported increases of between 50 and 175-fold in telehealth visits as compared to pre-COVID. 57% of providers view telehealth more favorably than they did pre-COVID, and 64% of providers are more comfortable using it. And I think most of us who are providers in one way or another out of necessity have had to use some form of telehealth. So it's not surprising that once we use it, that we become somewhat more comfortable with it. But also we discover whatever the shortcomings are, as well as the benefits. So there have been many barriers to seamless integration of medical and behavioral health care over time. So certainly number one here, cultural differences. So the culture within medical care, the way an office is structured, how appointments work, how things are documented, whose role is which, in the office. That culture is very different from mental health, and behavioral health care has been somewhat mysterious, of course, for many years, especially when it's not been co-located. And sometimes it is somewhat more mysterious. The communication styles are different. The way that behavioral health providers talk about patients. I think the first time years ago when, as a doctor, I'm used to talking about patients. When when a therapist or another member of the team talked about the patient, it was the client or the member, something like that. And I'm used to that now, but that's just a simple example. The communication and what we mean by when we speak in person, and particularly in our records, the way we document is or has been traditionally so very different, making it difficult even if you have the record sometimes on the medical side to clearly understand what it is that we're saying, what we're doing for the patient on the behavioral health side. There are different hierarchies, of course, among professionals as part of the cultural differences between the way medical care and behavioral health care is delivered. It's not the easiest thing, as we all know, just to share records with HIPAA concerns, which are maybe sometimes interpreted almost too strictly by some providers, and then having to have released, produce the record, and get it over to the other side. Sometimes this is really a big barrier. And billing is not my expertise, but I certainly understand from those who work on that side that the billing is very different on the behavioral health side than it is on the medical side. And in both cases, it's anything but simple. And trying to align those things in some kind of way has been very, very difficult to do. And one thing that's not mentioned here as a barrier to integrating medical care with behavioral health care is I think, well-known behavioral provider shortages. There are shortages of therapists, prescribers, psychologists. 2/3 of primary care physicians in a study report not being able to access outpatient behavioral health for their patients. And I don't think this is a surprise to any of us. This is clearly the case. So you can't integrate the behavioral and the medical care if the behavioral care isn't there in the first place. So that is perhaps one of the foundational challenges.
I was talking to a primary care doc who was giving me advice as we continue to develop this approach and the platform. And he said, the only thing I'm interested in looking at the documentation, so I would advise you to put it on the top, is the diagnosis, the medication, how is the person getting better or worse, and what you're going to do next time you see them. Anything else that you guys do in behavioral health, I'm not interested in reading about. I don't have time. And so I think it just sort of goes to highlight what Kevin was saying in terms of expectations and communications and the way we think about it. He was trying to be helpful and say, you talk about patients different, you think about patients different, with minutes. This is all I have time for. And so I think it's how do we bridge these differences, if you will, so that this way we end up with a team approach. We reduce the historical and current fragmentation. So I think Kevin has reviewed that the landscape, which is there's a lot of behavioral health difficulties. Behavioral health difficulties share a correlation with medical comorbidities. Having a behavioral health issue costs more. And then sort of the reason why we need to integrate. And so what this slide speaks to is not only that mental health, that behavioral issues and medical go together, but that we actually have a significant impact. We have an impact on the effects, and we have an impact on cost. And so this slide speaks to that when you provide behavioral health treatment, you get a 16% reduction in cost, medical costs. And when they can't access behavioral health treatment, then there's an increase in cost. And I think it plays out on the right side of the slide, where if you're treating depression with diabetes, you end up with a savings of roughly $900 in 24 months. Or if you're treating depression in primary care over 48 months, it's $3,300. I do want to get back to a statistic that Kevin mentioned earlier about the 2/3 of primary care physicians report not being able to access outpatient behavioral health, because I think that we're usually accustomed to a lot of statistics, a lot of information. So I would just have you think about, what if that statistic was different? What if that statistic said 2/3 of primary care physicians can't access oncology for their a cancer patient, or 2/3 of primary care physicians can't access cardiologists? Or, I think it might have a different impact. It shouldn't, but I think it does. And so it just doesn't play out in the rest of medicine the way it does in behavioral health. And I think we should be have insight as to that.
I would add to that also that the lack of availability for outpatient care, or when it's available, the very long wait sometimes, really contributes to people not just not getting better, but often getting worse with their mental illness. And that's one of the reasons that the cause of hospitalization and of emergency department care is so much higher in those with mental illness, because they go to the emergency department. They're given a list of people to go call to get an outpatient appointment, and they can't get in with anybody, or there's a very long wait. And many times they just get worse. They're back and forth to the ER. Eventually they're in the hospital. But even then, leaving the hospital, it can be a huge challenge to find someone to follow up with them outpatient. So this really it really has a ripple effect. And of course, then they come in for more medical care as well.
Now we're going to sort of talk a little bit more about the aptihealth approach. And so, consistent with triple aim recommendations, a team-based collaborative approach is what's recommended. And so and it makes sense, because we want to reduce the fragmentation or the way we work in silos. So we've taken the approach that every member is assigned a care team, and our platform allows that assignment to occur. So every member, every patient is assigned a care team, and that care team is flexible. So you just have, you see here that you have a therapist, a prescriber, a case manager, and a physician. But we want to get to the point where, we can include a medical specialist, a residential staff, a family member. So whatever the member needs and wishes, our platform will allow us to work with the significant people in this member's life to make care more comprehensive and more effective. I think the other thing that our platform allows to do is to access documentation. So with an agreement and permissions, the physician or care manager at a physician's office can access our records. And so there's more collaboration going on. And again, the platform allows for this to occur. I think the other thing that we wanted to accomplish was to make sure that we were very person-centric, patient-centric about our care, that our care was resisted the temptation of kind of looking the same or drifting to sort of the same approach. And so in order to sort of accomplish this, we start with comprehensive, standardized, patient-driven assessments. And in our research, when you complement a comprehensive assessment with a clinical interview, you get 100% more information than just a clinical interview alone. And the other thing it does is it provides an opportunity for the patient to have a voice. If I interview a patient and then I document what I think, the patient's voice is minimized. But here, if we have a document that we then build off of, then they get an opportunity to tell their story. The second thing is we have a proprietary 15 life areas that we look at. And so the patient rates themselves across severity in terms of these life areas. And so these life areas identify potential treatment goals. And so again, heavily focused on the patient having a voice in a direction in terms of how the care plans are developed. The other thing, as we spoke about in the earlier slide, the composition of the care team is adjusted based on the patient, but also the frequency of care. So typically, what happens is we try to get the patients to a 90-day track where they receive, for example, individual therapy once a week. Now, a person comes in with higher acuity and can't access partial hospital or intensive outpatient. So we then increase the frequency. So we may increase the frequency to twice a week, whatever the patient needs. So in terms of frequency and in terms of who's on the care team, that's also personalized. Kevin made a point about sharing documents, and I think that we have tried to not only share documents, but we've tried to sort of make it simple for the provider. So an example of this is that when our prescribers prescribe medicine, that's a field that is found in the therapist notes. So the therapist always knows what's the most current medication that the prescriber prescribed, and the same thing in reverse. There's a section of the prescriber note that talks about the last intervention of the therapist. Again, we're trying to make it easier for people to be aware of the care that's going on across providers. And finally, we have our patients take a monthly PHQ-9 and G87. Every 90 days, there's a more comprehensive progress review, reviewing symptoms, functioning, healthcare use, et cetera. And then we determine, together we determine what's the best care, after that 90 days or for the next 90 days. And so we're data driven in terms of treatment decisions.
So it seemed to me, Alex, at first, when I was considering, telehealth and getting involved, that to some degree it might feel counterintuitive, the idea that technology can somehow improve the patient's care. I think because technology in much of my work history has been more limited to the EMR, which we haven't, some of us haven't always had really friendly, happy experiences with. But when we have control over what we put into the platform, how it works, where the information goes, and how it's shared, and how we can track progress through that, it's very impressive actually how the technology leveraging that as well as relationships with other providers, other members of the care team, the referents, how all of that together creates a much more effective treatment for the patient and much more individualized than we can do just alone in our office.
Yeah, I think that's a great point, Kevin. I think that, when you think of the EMR, there's value in structured data but usually that ends up being structured data that's a pop-down menu. And then, you know, we're limited or constrained by those choices, as opposed to having an opportunity to have the patient sort of provide a lot of information and direction. So I think you're absolutely right. You know, we've invested heavily in data collection, and we've done it for two reasons. One, to inform, and two, to achieve insights. So what you see on the screen is a typical dashboard. And so let's say let's use the example of a PCP. So the PCP has their dashboard, and from there they can see, you know, how many patients have referred, how many patients have engaged, where they are at in terms of their patient journey. Are they just referred? Are they going through an assessment process? Are they already in 90-day care? Are they beyond that? And so it gives you a feel for your panel as that is being provided care to by aptihealth. In addition, you know, it would be simple to just go to any particular patient and then see how they're doing. So this is sort of the data collection to inform. I think that the data collection to achieve insights is what you see on sort of the right-hand side. And so again, if you look at, you know, the triple aim, it's sort of member satisfaction, its outcomes, and its program value. And so, except for the HEDIS measure, which is important, and also sort of a process measure, the other three data categories are consistent with the triple aim, and put us in position to move towards a value-based or a performance-based contract, because it's the collection of data and the insights we have that that are very important. I'll give you an example. So the data started to reveal that when a patient makes an appointment very soon, let's say 3 days, they're more likely to complete 90-day treatment. Whereas if they take 12 or more days to schedule their first appointment, there's a higher likelihood of them dropping out. Well, this is an important piece of insight, because if it's true and we know that, now we can do something to help the higher probability of attrition folks to intervene so that doesn't happen. So it's having the data with a plan of whatever the data says, then it tells us how to change to be even more effective with particular cohorts. I think that you know, one of the early sort of conversations about aptihealth was the recognition of healthcare being so fragmented, and behavioral health even being more fragmented within the healthcare system. And so we wanted to reduce the fragmentation. And so if you look at increasing access points, that's important in reducing the fragmentation. So for example, emergency rooms have a roughly 15% of the visits are behavioral health related. So there's 15% of behavioral health related visits where they may not have an opportunity to offer an appointment before discharge. And the likelihood of them following up with behavioral health without an appointment, with perhaps just a list of providers, the likelihood of follow-up is really low. So by knowing that there's a certain percent of behavioral health folks across these settings, and by increasing the access and the speed to care, is important. Again, one of the recommendations is for a healthcare a system to have an integrated behavioral strategy across the continuum. And so if you look at primary care, specialty care, urgent care, emergency department, and inpatient, those are the big those are the big components of a health system that would be the continuum of care. So again, by trying to make it easy for them to collaborate and get access to behavioral health care, I think is important in reducing the fragmentation. And we're moving in that direction. We're now working, for example, with emergency departments to try to create that sort of pipeline, if you will, of communication and referrals. So it's important that that if we're going to deliver care, that we maximize the ability of a platform so that it allows our providers to provide effective, efficient, and consistent care. And so what we did was we took I'm going to use the therapy as an example. So we took a therapy session, and you can't see it because the slide may not be big enough, but on top, we took a therapy session and we looked at milestones in a therapy session. So in a therapy session, typically you ask the person how they're doing, and then you ask them about changes in their environment that may have something to do with how they're doing or their symptoms. And then after you gather that information, you intervene, you do some evidence-based practice, and then what we wanted to do is make sure that it wasn't that the behavior change was not occurring in session, but also outside of the session. So we encourage our providers to work with our patients in terms of what's the plan in between sessions. So and then schedule the next appointment. So that's a typical sort of path, if you will, for a therapy session, and that's what's highlighted above. And before the therapy session starts, the patient has a window where they're asked some questions like, how are they doing, medication compliance, any changes in healthcare or healthcare use, etc. And that the answers to those questions are provided in real time to the provider as they're doing their session, so that this way, we have real-time data for the providers, and we help the patient, because we've all, I think, had the experience of going to a doctor and say, we're going to say these things, and then leaving the doctor's office and forgetting some of the things that we said. So we wanted to ensure that that doesn't happen. On the bottom, you see the care plan objectives, and alongside it, you don't see it, but it says care tips. Care tips is the explanation for what to do during this screening. And again, it's so that all providers can look and we provide consistent care. So again, the overall goal of this was not to just just do therapy on a video conferencing. We wanted to make our virtual session much more sophisticated in terms of data collection, in terms of having access to data at the provider's fingertips so that they can do real-time sort of clinical decision-making, et cetera. And the same format for med management.
Yeah, this is much more useful in my experience so far than what happens in a lot of places where you have, Zoom or some other platform where you have the patient on one computer. You have 2 or 3 computers on your desk because you have the patient visit happening on one, you've got your electronic record on another, and then maybe another one where you have to look up labs or some other information. And this is all integrated and really making sense based on what information we need, and in the way that the patient is answering some of these questions while they're waiting to join the session is just great. They've just thought this, they've just answered it. We can talk about it. This is really advancing beyond just teletherapy as the portal to interact with the patients, much more than that.
And so we wanted to share with you, some of the outcomes from our work. And so the first set is mostly sort of process measures, but we get patients into care within 7 days. I think the last time I looked, the median was 4 days. We have our patients be very cooperative or engaging with our assessment process. So they complete this self-assessment, and you see a very high rate of 96%. And the patients that are admitted to 90-day care, 81% complete the 90-day care process before then other decisions about what to do after that occur. I think that from a symptom perspective, we've shown that there's a 60% reduction in depressive symptoms within 90 days. Actually, the latest data suggested that we're achieving that in about 60 days. And same for anxiety, that 57% reduction in anxiety symptoms within 90 days. And again, the latest data showed that the impact, we were achieving that impact a little bit sooner. And then again, you have to, if the person is better, they're going to use less healthcare. And so we show that there's a reduction in emergency room visits by 68%. And then the last thing is, well, how easy is it to sort of, use aptihealth or work with aptihealth? And remember that Kevin said that in the collaborative care model, which is a well-documented, well-researched model, but in that model, there's a heavy change management on the PCP side. And so here, it takes about an hour to onboard providers. We provide some training and then onboard them. It's very easy to refer patients to us, and the case managers that we work with at many primary care sites, they feel good about their work with us. They feel like they have had easier and faster access to care, and that there's collaboration that is ongoing. That's helpful them to understand and usually report back to the PCP what's going on with their patients during PCP visits.
Well, so finally, we've reviewed the behavioral health crisis. We looked at the state of integrated behavioral care. We considered the evolution of integrated behavioral care, talked about some of the barriers to integrated care. We highlighted some of the benefits of integrated care, then focusing on the possibilities of virtual behavioral health care, including improved access and use of data insights to redefine care delivery. We presented some evidence of the benefits of aptihealth's approach to integrated behavioral health care. And now we look to the future. And of course, Alex and I believe very strongly that the future of integrated care and telehealth will go together. Telehealth being, behavioral healthcare being so amenable to telehealth in its delivery, and also so much more accessible in less urban areas. Telehealth is the way that we're going to be able to not just provide behavioral health care, make it accessible, but also through the technology and relationships to integrate with medical care. There are challenges that remain to overcome. One of the big ones we mentioned before is the overall shortage of behavioral health care providers. If you have two of them in your town, and you don't really have two in your town anymore if one of them is virtually providing care to another town 100 miles away. So there still is a societal challenge, basically, to increasing the number of providers and then leveraging the telehealth to reach the patients where they are. And partnerships, again, these relationships are absolutely necessary, and we have to continue to improve on those and to get our cultures to line up, or at least to understand each other enough to communicate well and work together.
Yeah, I would only add to what Kevin said that, you know, we have a lot of work in terms of analyzing a lot of data that will help us improve care over time, reduce fragmentation, build better relationships, closer relationships with the entire medical community. So I think that, you know, I think as Kevin said, you know, telebehavioral health, I think is here, and it's not going anyplace. And so for us, it's, if we build the foundation right, then, you know, this behavioral health evolution is probably at its infancy, and it's exciting. I mean, you know, anything that's also new or causes us to change is a little bit scary, but I think it's from our perspective, it's very exciting.
Absolutely.
I think, Kevin, we would welcome questions, comments. I don't know if there is any, but we would love to start a conversation with the audience.
Thank you so much, Alex and Kevin. Currently, I don't see anything in the chat, but to all of our participants, I encourage you to ask any questions you may have, or if you want to have a dialogue, feel free to pop anything into the chat. And I see now that there's some contact information on this slide if anyone is interested to jot that down as well.
Yeah, any questions, anything you want to find out more about us? The good looking guy on the right of the slide, his email is there, and he'd be happy to.
Hey, good looking guys on the left.
And he'd be happy to field any questions, and whoever the question, you know, we would get back to you happily. So, well, if there are no questions, then I guess, you know, I don't want to speak for Kevin, but I think I will. Thank you for attending this session. I hope that the information provided was either helpful or thought-provoking, or any of those things. And so thank you for attending the session.
Thank you so much to both Kevin and Alex for taking part in the summit. So this is actually our final session of our week-long conference. I want to thank everyone who took part in any of our sessions, as well as, of course, our sponsors. And as a reminder, all of the sessions are going to be archived on the website if you want to look back at any of the slides or presentations that you might have missed. And with that, I want to say thank you. Have a wonderful afternoon and great weekend, everyone.